So good afternoon, everyone. Happy last day of September and happy Friday. Our topic for today is a little bit of a continuation from the one that I did just recently. And this one is focused not necessarily on SSRIs and weight gain like the last one was, but looking at the role that SSRIs can play in the treatment of anorexia. So our objectives for today, so we're going to look at the symptoms that are commonly associated with anorexia and talk about why the SSRIs may actually play a role. We're going to take a look at the treatment recommendations. So what are the consensus guidelines related to treatment of anorexia? And then we're going to compare the efficacy data specifically for the SSRIs. So we'll look at it's not all of the trials because this is supposed to be a didactic blitz, but a large number of the clinical trials that are available for our SSRIs. So to start off with, I wanted to look at the symptoms of anorexia. Common symptoms that we see are restriction of energy intake, weight loss, fear of weight gain, and distorted body image. I wanted to pause right there for a second. I do think in terms of restriction of energy intake, there's a relationship that's been established between serotonin levels and satiety. So the higher the serotonin, we tend to see more satiety. So we would expect patients to feel more full and therefore not take in quite as much food. So it doesn't seem incredibly clear why we would want to add serotonin boosting agents on board. The weight loss, what we talked about a couple weeks ago was the fact that the SSRIs are sometimes associated with weight loss initially, but we do see weight gain in the long term, although that's not always, it's not clearly associated with the medications as much as it has been associated with improvement of the depression symptoms. So again, maybe not seeing some of the other agents that are used, things like olanzapine, have evidence of weight gain as an adverse effect. So that isn't incredibly clear why we might be trying to target the SSRIs. The last two, I really think, are where a number of the considerations for the use of SSRIs for the treatment of anorexia come into play. There are different subtypes of anorexia, restricting type, there's a binging purging type. They're looking at a number of other types of anxiety disorders. So ARFID being one of the others that's restricting food intake. So a lot of that anxiety, not just about weight gain, but regarding body image, regarding the food that's being ingested, and a number of factors around that in general. That may be more where we start to see some rationale for why we would use the antidepressants. Why are we looking for additional treatments of anorexia in general? It has a tremendous impact. It's most commonly diagnosed in individuals who are in their mid to later adolescence. It can have a number of different health impacts when individuals have lost a significant amount of weight and are malnourished. We see cardiovascular issues. You could see hair loss. We do see amenorrhea. There's a significant impact on bone density. Their growth curves shift. So from the nomogram of growth curves, you can see a tremendous fall off depending on how much weight the individual has lost. And this time is really important. In adolescence, we're finalizing a number of the different connections, including some of the main neurotransmitter pathways. So starving those neurons could be really problematic in the overall brain maturation. On imaging, patients with anorexia do tend to have lower gray matter than what we see with their counterparts that don't have any type of malnutrition or any eating disorders. And there's also been a number of different explorations done of not only serotonin, but norepinephrine, the opioids, as well as dopamine, to try to see if there is a rationale, a pathophysiology that we could trace so we could have more targeted and effective treatments for anorexia. We aren't seeing any. These patients do tend to have lower cerebral spinal fluid concentrations of the 5-hydroxyindole acetic acid, so the metabolite of serotonin. So they tend to have lower amounts of that, concentrations of that, suggesting maybe they don't have as much serotonin. With their dietary restriction, maybe they're not taking in as much tyramine, so they don't even have the building blocks to make additional serotonin. These would be reasons why we may need to boost that neurotransmitter in general, even though we know that it's been associated with satiety. One of the other main reasons why finding treatments for this condition is so important, this actually has the highest mortality rate of all of our mental illnesses. So the mortality rate for anorexia is 9 to 14 times that of the general population. The mortality is the result of a number of different things. Medical complications due to malnutrition lead the way, but suicide is a close second. Suicidal ideation has been estimated to be found in between 20 and 43% of patients every year. The lifetime prevalence is considered to be upwards of 75 to 80%. This population also is much more likely to attempt suicide. So the suicide attempts are up 1.5 to 9 times that of their colleagues. So as the eating disorder starts to get taken under control, some of that discomfort may manifest itself in self-harm type behaviors, including suicide attempts. So high burden for the patient, high burden for their family and their caregivers. So what are we supposed to do about it? Well, there aren't necessarily evidence-based treatment guidelines to go off of. Most of the recent treatment guidelines are consensus-based. So based on the literature that we have that's available, here's what the experts are recommending. These treatment guidelines, I believe, are from 2019. And the main treatment intervention that's recommended for anorexia patients is nutrition management. Supplementing what they've been taking in, quite a few of them will have extensive treatment regimens in terms of their nutrition. They often will use mottos that say, food is your drug, food is your treatment. That tends to be the mainstay. Psychotherapy also is recommended. It's not often initiated with all patients immediately upon diagnosis. There are a limited number of therapists and counselors that specialize in eating disorders, and this is very different than those who are usually counseling patients on depression or even anxiety. So yes, there is anxiety related with the eating disorders, but there is a very different approach that's taken between the two. There's a lot of discussion about the different modalities or types of therapy that are used for patients with eating disorders. Many of them encourage cognitive behavioral therapy, the use of motivational interviewing, and an incorporation of some type of family therapy. So for those that may be around the patient, regardless of whether it's an adult or it's an adolescent, they do encourage them to be part of the treatment because they're going to be asked to weigh in on the progress of the individual. One of the other first-line recommendations is to manage comorbidities. A number of different comorbidities come along with eating disorders, anxiety and depression being two of the more common. We can see some substance use disorder. I would say for the anxiety disorder patients, not quite as common. Many of them will refrain from the use of alcohol because it is a caloric beverage. So that's something that they're not necessarily exploring and looking for opportunities to utilize. When it comes to medications themselves, the actual recommendation in the guidelines is that antidepressants are not recommended for achieving weight gain. So they're not recommended for the treatment of anorexia. And I guess I probably could have stopped right there in terms of the presentation, but I wanted to take a look at why. Why do we have that in terms of a recommendation when we really are using this in a number of patients with anorexia? And to prove that we are, other than just what I'm saying, this was a cross-sectional survey that was done in England. They looked at 44 different sites. So they used 44 different locations of health centers that had eating disorder programs. And they surveyed almost 100 of the healthcare providers that were there. Most of them were psychiatrists, not all of them were psychiatrists. The patients who they had with a primary diagnosis of anorexia, less than 10% of them are on psychotropic medications. So it seems pretty consistent that no, this isn't something that we're using first line for most of these patients. But of those that are using medications, olanzapine tends to be the main agent that's being prescribed. Fluoxetine is number 2, with sertraline kind of being a little bit more of a distant 3. So the SSRIs are represented in the few patients that we are treating. So let's take a look at how effective they are for this patient population. Here's a list of all of the SSRIs. I forgot to mention something on that last slide. So of these SSRIs, most of them have been reported to actually make anorexia worse. So there are case reports of individuals who did not have an eating disorder who did present with symptoms of anorexia. And that's true for most of these agents. So there is a little bit of that. I did not come across any controlled trials really looking at the prevalence, but I did just want to represent that that was there. So we have 3 of the SSRIs that have little marks next to them. So for the 2 that are have the asterisks, fluvoxamine is not used for anorexia. It has some evidence for bulimia, but there really was not any literature available looking at only patients with anorexia. Most of those patients had the eating disorder trials that included anorexia patients had a mix, and most of them had bulimia or binge eating disorder. So it was tough to pull apart and say this is how effective it was. So I'm not including that one. Citalopram doesn't have any evidence. We do have some for citalopram, so that one's staying off. And sertraline, even though that was number 3 on the list, only has 1 open label trial that included 12 patients. So they did see some improvement in depressive symptoms. They did not see any change in weight. And they were equally able to maintain their weight up to a year afterward as the placebo patients. So we're not going to include that one either. We're going to spend time looking at the other medications in the trials that are available. So citalopram I started with just because it's alphabetically, it comes first. And what I've done in most of these slides is there's one trial in the column on the left, there's another trial in the column on the right. There are quite a few case reports of citalopram being effective for anorexia. There also was a case series. Now, this case series had patients who were treated in an eating disorder clinic that had citalopram and also were given some type of psychotherapy, be it individual, group, or family psychotherapy. Their BMI, these were relatively severe patients. Their body mass index was 15 to start with. And these were all reports of after they had the treatment with the citalopram, by the time they got to the endpoint, their body mass index was 12. So it had dropped pretty significantly. There was an average weight loss of almost 10 pounds. And this was over, it did not give us a duration of how long that was. Those BMIs just, so I'm 5'5", that would be someone who starts at a weight of 92 pounds and ends up at a weight of 74. So they were not finding the citalopram to be effective. To be fair, it was a case series. These were more of the severe patients that were being treated. They tended to be in their early 20s and had failed monotherapy with psychotherapy. So they were looking to try something else, but they already were trending in a negative direction or a not positive direction, I guess. But they did not find any evidence that this would be helpful. So what else do we have? Well, there was an open label trial that looked at citalopram 20 milligrams along with psychotherapy. Again, the numbers were really small, so this was only in 6 patients. This lasted for 8 weeks, and they did see a decrease in the eating disorder inventory. So this is a survey that's administered to patients with eating disorders. It's in its 3rd rendition now. The 2nd version was used in this particular trial, but this looks at much more than just the amount of food that someone's taking, the anxiety that they have around that. It looks at a number of other behaviors. It looks at their drive to be thin. Is that the main indicator for those patients? It looks at body dissatisfaction. It looks at distrust, distrust of self or others. It looks at some interoception. So are patients having some alterations in what their own personal perceptions are, as well as things like ineffectiveness, where they feel like they're unable to get things done, which may bring guilt along with it. Compared to the baseline, they did see improvement in all of those. They did not give us the specific numbers for this particular trial, but it suggested that maybe for some of these patients, this could be beneficial. Not just looking at weight, though, possibly looking at some of those other symptoms. So what else do we have for citalopram? There was a slightly longer trial, so that last one was only 8 weeks. This was a case control trial that lasted for 3 months. Patients were given either citalopram or put on a wait list. That seems slightly cruel, but there is really limited resources for treatment of eating disorders, so that would not be uncommon. What they found was that there was a minimal change in weight. So we have weight, the body mass index, and then scores on the Beck depression inventory. This is citalopram at baseline, citalopram at endpoint, then the wait list group at baseline and at endpoint. We did see a slight increase in the weight of patients who were on the citalopram. There also was a small increase in weight on those who were on the wait list as well, but not a huge bump in the body mass index. So it didn't take them up to a normal BMI. We did see a pretty significant improvement in the Beck depression score. So it didn't change for the wait list patients, but it was cut in half from more mild symptoms to virtually no symptoms, or what would be considered the normal range. So they did see an improvement there with just a minor change in weight. So maybe there is some improvement, especially in patients who may have more mood symptoms. This other trial was an open label trial for 6 months. Again, they used citalopram 20, so they really weren't pushing the dose of this. That's going to be in contrast to the fluoxetine. This one, they just had satisfactory response or unsatisfactory response. They did that based on changes in weight, whether or not the patient got their menstrual cycle back, because these were all females, if there was a decrease in the number of symptoms that they were endorsing, and that same eating disorder inventory. So if they saw positive moves in those categories, it was considered a satisfactory response. A little less than half did have a satisfactory response. So for at least some of those patients, it does look like that could potentially be beneficial. Maybe not specifically for the weight improvement, but for some of those other symptoms that could be distressing. So maybe a little bit of efficacy for citalopram, probably not enough to justify its use, especially before some of our other treatments. Paroxetine, there was a little bit of data. So there was a case report. This was in a patient who had comorbid conditions, so obsessive compulsive disorder, as well as a personality disorder, so the schizotypal personality disorder, and anorexia. Patient had been admitted to the hospital with pretty significant anorexia and OCD type symptoms. Patient was started on paroxetine and titrated up to 60 milligrams with significant improvement in symptoms. So they saw a robust response to the point that the patient could be discharged. Shortly after discharge from the hospital, all medications were stopped. Symptoms returned. Patient was readmitted to the hospital and then restarted on the paroxetine with, again, a pretty significant response in their symptoms. So that would suggest that at least for this patient, it did appear that it could be beneficial. That was one patient. Can we look at a slightly larger group? So this was a retrospective review that was done on an inpatient eating disorder unit. So there were 83 patients. All of them had a diagnosis of anorexia, and they were treated with either paroxetine or clomipramine. Tolerability was a big issue. So approximately 30% of the clomipramine patients did drop out, and about 15% of the paroxetine patients did discontinue therapy. Most of them were adolescents. The ages were between 10 and 18, but they did see a change in weight. So these are in kilograms. So the paroxetine group had a 2.5 kilogram improvement, and the clomipramine group had just under a 3 kilogram improvement. Now, these were patients for the paroxetine group that were treated for just over 2 months. They were able to get about a 5 to 7 pound weight increase. And for the clomipramine group, they were treated for about 3 months, and they were able to get almost a maybe 7 to 8 pound weight increase. So it did look like it was beneficial for them. Granted, they were in an inpatient environment the entire time, so they were given the prescription and not given the opportunity necessarily to refuse it. Plus, they were on standardized observed meals, which may have helped improve that weight overall. But possibly there is some improvement with the paroxetine. There wasn't much with that one. We had the best and most amount of data with fluoxetine. There are quite a few case reports that do demonstrate improvement in weight restoration and depressive symptoms. Now, weight restoration being maintenance in weight restoration. So patients who have anorexia, who are malnourished, they want to restore their weight and then have them maintain. So they really try to get them, especially the adolescents, back up onto their growth curve. So they found that maybe not acutely, but more long-term, that the fluoxetine had been beneficial for them. There was a single blind trial that was done in inpatient, so those that were a little bit more acute, and they were split into 3 different groups. So clomipramine, fluoxetine, or amisulpride. Their baseline weights are in kilograms, so between 37 and 40 kilograms. Their endpoint weights for all of them, they increase, but not by very much. So we were looking anywhere from 38 to about 43 kilograms. Both the fluoxetine and the amisulpride group, that was considered a significant increase from baseline, but likely less than what they wanted, being that this was a 3-month trial. They really would hope for more rapid restoration because that helps prevent some of the consequences of malnutrition. They also looked at some of the rating scales and the subgroups of the rating scales, the subscores. So this was obvious weight phobia. So the percent of patients who had obvious weight phobia at baseline was between 60 and 90%. So the amisulpride was a little bit of an outlier, with most of those patients having significant phobia at baseline. By the time they got to the endpoint at 3 months, there was significant improvement for the clomipramine group, where only 30% were reporting obvious weight phobia, and it had dropped to about 50% for the fluoxetine group. So that is beneficial. Maybe this is helping a little bit with weight, but helping with some of those anxiety symptoms that may be undermining some of the nutrition management that's being put in place. The doses that they used for this, the fluoxetine was 40 milligrams. So they were looking at boosting the dose a little bit higher than what we saw with the citalopram group. This next one is just one trial. So this was a randomized double-blind placebo-controlled trial, small group, a little bit older patient, so in their 20s. Again, initial diagnosis tends to be in adolescents. So this is looking at more young adults. They encouraged patients to go up to 60 milligrams, and they were pretty successful with the average dose being 65. They saw improvement in both groups. So the weight was reported as percent of ideal body weight. So to start with, they were about 70% of their ideal body weight. So they were even below what their ideal body weight was. And by endpoint, at the end of those 7 weeks, they were closer to 90% of their ideal body weight. So getting closer to where they wanted them to be. The anorexic behavior scale, so this is also a rating scale. It looks mainly at eating disorder behaviors, things like taking really small bites, eating really slowly, and any type of binging, purging behaviors. And they did see an improvement in those scores from baseline to endpoint. They weren't zero, they still had essentially moderate symptoms, but there was a trend in the right direction. And then for the Beck depression inventory, so again, they used the Beck and we saw an improvement in both groups from baseline to endpoint. So improvement in some of those other symptoms along with an improvement in weight. So not clear if it's helping with weight, which helps with the symptoms, or vice versa. We help with the anxiety or depression, and that helps increase the weight. This is starting to look a little more long-term. So this is a long-term illness. The first trial was an open label 11-month trial. Again, a small number of patients that were started inpatient and responded to fluoxetine. What they found was that the weight that was 85% of the average body weight, so they used a different marker, patients were much more likely to be maintained closer to that threshold, so at 85% or above of the average body weight, if they were on the fluoxetine. They also had reported improvements in their mood and obsessional compulsive symptoms. And patients overall tolerated the fluoxetine pretty well. They had quite a few of those patients were able to stay in treatment for the full 11 months. So it looked like for the patients that it worked for, that efficacy was maintained longer term. Let's look at it in a controlled trial though. So this was a randomized double-blind placebo-controlled trial for 1 year. Patients had to start out either inpatient or in an intensive outpatient program. There were almost 100 patients, and their primary endpoint was time to relapse. So if they started losing weight, that was considered a relapse. Unfortunately, both of them had more than 50% of their patients that relapsed. Although there were more patients of fluoxetine who remained in the trial. So again, there may be a subset of patients that respond to this that do well longer term, but overall, it really didn't make an impact for about over half of the patients. So it doesn't look incredibly promising. So we're seeing a little bit of improvement, but it's not likely for those anorexia symptoms. One thing to keep in mind as we move forward, there are a couple other antidepressants moving into this space. Some of the serotonin norepinephrine reuptake inhibitors. They're also looking at things like mirtazapine to be used here. But it really depends on who we're looking at. Some of the big issues we have with those clinical trials, we're looking at all different age ranges, from individuals who are 10 to 12 to those who may be in their mid to upper 20s. They respond very differently based on where they are in their illness. What type of comorbid conditions do they have? Some of them allowed mental health diagnosis, some of them did not. How long are we treating them for? Likely we're going to need to see these trials be longer than those 7 to 8 weeks just to see if there is any improvement, because it doesn't look like it's treating the symptoms of anorexia as much as it's treating some of those other symptoms like depression or anxiety that may be driving some of those eating disorder behaviors. We're measuring all kinds of different things. We even measure weight differently, sometimes by body weight, sometimes by ideal body weight, sometimes by average body weight, sometimes by the percentage of people who are back on their growth curve. So we kind of need a consensus on what it is that we're going to measure to say that this is effective. It makes a huge difference if it's inpatient or outpatient. Inpatient would suggest we're trying to try this to help them gain weight, whereas outpatient may be much more on the maintenance side. And we kind of flip-flop back and forth with most of those. Antidepressants across the board don't seem to be as efficacious if a patient starts with a really low BMI. So if they're significantly malnourished and their BMI is in that 12 to 14 range, their body isn't able really to utilize the antidepressants quite as well because it's in starvation mode, just trying to take care of the bare necessities. We are getting a couple different types, subtypes of anorexia being identified. So as I said, it may be very likely that there's a subset of these patients that respond. So it's going to be a little bit more trial and error versus just across the board being able to prescribe an antidepressant. So in summary, fluoxetine has the best evidence. So if we have to use one, that would be the one, although the evidence is a little bit inconsistent. It's much more likely helping with some of those anxiety or depression symptoms. Depression has the most consistent data showing improvement with the use of the antidepressants, and we're not likely targeting those specific symptoms of anorexia. So this would not be a class that should be a mainstay of treatment, but may be really beneficial for some of those patients who are struggling with anxiety and depressive symptoms that are making that eating disorder picture much more complicated. So with that, I will stop my share.